right, let's go ahead and get started. With the remainder of our afternoon program, so it is my pleasure to introduce Dr. Natasha Gatson, MD, PhD, and she's a fellow in the Academy of Neurology. She is the medical director of neuro-oncology and an associate professor of neurology, medicine and neurology at Banner MD Anderson Cancer Center in Phoenix, Arizona. She's recently relocated from Danville, Pennsylvania to Phoenix, Arizona. But she still is an adjunctive professor of medicine at Geisinger School of Medicine. Her major clinical interests are the neuro-oncology of women, population science, and brain tumor imaging. And it's my pleasure to call her a colleague and also a dear friend. So Natasha, I will let you, Dr. Gatson, go from here.
Yes, thank you very, very much. It's been my pleasure and such an honor to work with Janet and Angela, really, and you as well, Amy, and getting this conference going. And I've just been very lucky and fortunate to stay in the loop with you powerful ladies. Um, I had an interesting topic, that's really within my wheelhouse that I really love to address, and it's trans health. And I want to be very clear, this issue of trans health in all of medicine, is very interesting and it's not well understood. But in neurology, there's even more of a difficult, crossroads. And I hope to be able to touch on some of that. I'll be able to talk a little bit about cross-sex hormones, which, people are exposed to in the gender affirmation and transitioning period, and talk a little bit about things that we might be able to do better and being able to best capture the needs of this population. And I'll make it very clear that nothing about this talk has to do with any it's not gay, lesbian. It's 100% trans health, and we want to make sure that we're very clear on keeping these understanding individual groups and what their specific needs are. So with that, I'll open with a case of a 32-year-old obese patient arrived to the hospital with severe abdominal pain. The patient did notify the ED nurse of their transgender status and reported several years of various reproductive changes. The patient also noted exposure to cross-sex hormones, but then lost their insurance and could no longer afford neither the hormone therapy nor their systemic medications. What would you do next? So I was very careful not to give away any gender, anything like that. We understand there's a 32-year-old with abdominal pain, some issues with health insurance, and in the process of transitioning. So you get a patient with severe abdominal pain, but the layers start to come on when we think about what would we do next in those particular patients. Of course, everybody knows the airway, breathing, circulation. You get the history exams, labs, maybe some imaging, symptomatic control of the pain. But then you understand that this is an obese patient with severe abdominal pain. And so here you may start to focus in a little bit and try to see if there's any dietary triggers, gyne obstetrics, try and think about the things in the abdomen, that may be clouded or exacerbated by, obesity. Being able to look for pregnancy and infection and things like that. However, then the patient has another complication that sort of lays on in the interview. This is an obese, uninsured patient with severe abdominal pain. So now you're maybe having to think, okay, well, this is an uninsured patient. Either maybe there's a little bit of hesitancy on the part of the institution. Do we give them all this big bill to pay versus trying to focus the exams and potentially get more opinions about what to do next? Then you find out that this is an obese, uninsured patient, medication non-adherent patient. So whether they understood if the patient could get the medications, no matter what, they're non-adherent for all of their systemic issues. And now you start to look at this patient potentially through a different lens. Is there something that you're going to be able to do, even if you prescribe things to go home with? Will they be able to continue it? Maybe there's a potential for blame and shame, the patient. And now the emergence issue that they presented with becomes secondary because there's so many layers here. And then you add the transgender layer. Here, nobody knows how to proceed, but truthfully, we have a patient with severe abdominal pain, and we can start there. The actual case that took place in 2019 was at NYC Langone Medical Center, where a 32-year-old trans man came in pain off all of the testosterone hormones that had initially blocked ovulation and menstrual cycles, but now off the hormone due to loss of insurance. The patient noted that menses has been, sort of off and on sporadic, and then past 3 months, nothing. Well, the patient noted to the ED team that there was a home pregnancy test that they tried, and the pregnancy test was positive. So right away, the ER team did the necessary studies, a pregnancy test, they planned for ultrasound imaging, but there was a lack of urgency to treat this patient. A lack of urgency led to the patient being triaged to the side and made to wait. And they totally missed all the signs of labor. And this was the USA Today headline. Nurse mistakes a pregnant transgender man as obese. Then the man births a stillborn baby. You can see all the little pieces in there that are really triggers, a mistake, and then transgender, and then the word obese, all of these, emotional things thrown in, and then you see man birth stillborn baby. It's all sensationalized. And the sad thing here is that the nurse took the fall. One of the doctors that worked there noted that this is an example of what happens to transgender people interacting with our healthcare system. So upon completion of this activity, I hope that the participants are able to discuss specific disparities and inequities that take place, when we're delivering obstetric and neurologic care as it pertains to transgender persons. Identify institutional, policy, education, research, and health literacy opportunities to encourage belongingness in healthcare, and increase awareness of the medical concerns that are faced by transgender patients so that we can move toward practice-changing approaches and improve their outcomes. So as you noted in the beginning, I went to Indiana University for a bachelor's in bio and psych. Then I got my MD PhD in molecular virology, immunology, and medical genetics, and completed my residency and an enfolded neurosurgery research fellowship at The Ohio State University before going on to MD Anderson Cancer Center, where I completed my neuro-oncology fellowship. I went on to Geisinger Health, as Amy noted, and I directed neuro-oncology there, but I also rose to the level of Assistant Dean of Equity and Inclusion, and that really started to open my eyes to the number of people that we really do in our curriculums. We miss being able to really evaluate. And I've stayed on as adjunct professor as we developed the social justice curriculum there at Geisinger, but now here at Banner Health, still doing some of the same work and really working to move into that same area while we're teaching our medical trainees. So I'm leading a subfield that's emerging within neuro-oncology called the neuro-oncology of women. This specifically deals with the science and the outcomes that are related to women's issues in neuro-oncology. This has to do with things such as the entire profile of changes that takes place over the lifespan of a woman, from puberty to menses to pregnancy and pregnancy prevention, as well as menopause. This also includes exposure to iatrogenic hormones, hormone replacement therapy, cross-sex hormones during gender affirmation. And finally, I focus a little bit on the things such as how cancer or cancer therapies impact quality of life, psychology, body image, sex, sexuality. So these are really very important issues that are not well dealt with. And I've recently had the opportunity with Dr. O'Neill to write an AAN article addressing, some of these issues in neuro-oncology. I've always been interested in pregnancy and how it interacts with the neurologic system and specific brain tumors. And this was an image that I developed. As a matter of fact, in high school, I was voted most likely to become an obstetrician. and really, really, enjoyed the field, but the brain took hold of me. And so I made up this quote that says, as a neurologist, my fascination with the uterus is hysterical. So again, going back to that, sort of sensational post in the news about the nurse making the mistake, the nurse and the patient, takes the fall in this situation, but it took that entire village in the emergency room to fail this patient. The patient had only the responsibility to seek medical care, not to limit anybody's liability or do any of those things. When I talk about statistics and trans health in general, we don't even know how many Americans identify as transgender. I can tell you for sure, as medical uh, professionals, we sort of assume what people are when they walk in, and we assume if they look transgender, they look, we sort of make all those inferences. And it used to be okay when you would just say male female when those were the only two boxes on there. Unfortunately, there a lot of EMRs now include a wide variety and even have other. And so I think that we need to be very careful this way and make sure that we're really accounting, for transgender people. So what you'll notice is that we estimate in America and United States 700,000 or so, and this is all data from more than 10 years ago. There's an estimated more current estimation of at least 25 million persons worldwide. The US Census Bureau still offers male, female. Transgender people face a higher suicide rate or risk. 41% interviewed, and this is all from one particular study, 41% had attempted suicide as compared to the general population's attempt of 1.6%. That's massive. That needs to be addressed. Poverty, big problem in the trans community. 2 times the rate of unemployment and 4 times more likely to have households that are headed by people who make less than $10,000 per year. This is tragic. And we look then even further, rates of housing and employment discrimination, and now health discrimination, which is one of the worst inequities a person could suffer. 19% of people surveyed said that they were actually refused care. 28% say that they were harassed in a medical setting, and 50% had to teach their providers more about trans care in dealing with them. I wanted to show you this map, and I'm going to pull them both up at the same time here. So 2019 is on the left, 2021 is on the right, and this has to do with transgender health laws. So in 2019, you can see 23 states explicitly covered healthcare for transgender people. And that's even dealing with the transitioning process, the hormones, the surgeries. 21 states had no real explicit laws or coverage for healthcare and for transgender people. 6 of those states explicitly said, absolutely not, we will not cover it. Well, fast forward to 2021, what you see is that the same number of states still explicitly cover. Where we're seeing the change is that there's a reduced number of states that had no law in place and an increased number of states that said absolutely not. So that's a step backwards in all of this. And some of that had to do with what we show here on this next screen, where certain states had initially said, oh, we'll use civil rights laws, laws that were initially written and very broadly to cover the civil rights of humans. And that had a lot to do with the Black movement, to be looking for equality and opportunities and public settings and education and things like that. But they were able to use those same words to say, this is a medical necessity, and we can use those rights. In early 2019, that was decided by the state. And then just months later in that same year, the governor signed a new bill into law that said, we can allow certain state-funded insurance agencies to opt out of that responsibility. And we all know as medical folks, when Medicaid and Medicare makes a decision, a lot of insurance companies follow. That's how we lost states, in general, that were willing to cover. I found this poem that I've always heard people kind of say in different ways by Martin Molière, The Danger of Indifference. So first they came for the socialists, and I did not speak out because I was not a socialist. Then they came for the trade unionists, and I did not speak out because I was not a trade unionist. Then they came for the Jews, and I did not speak out because I was not a Jew. Then they came for me, and there was no one left to speak for me. I think we need to understand that what we do for one of us, such as civil rights, and this with a point that Martin Molière makes, we do it for all of us. So when we look at some of the trans health facts in neurology, very, very understudied, area, but very important. By far, out of all the different subfields within neurology, epilepsy has done the best job at understanding how trans health is important to effective outcomes and treatments. And so we do know that anti-epileptic drug effectiveness has been influenced by circulating estrogens. We also understand that testosterone exposure can worsen sort of some reproductive cancers. Initiation of cross-sex hormones exposure can worsen epileptic seizures. This is especially true in male to female transition. Initiation of cross-sex hormone exposure can improve catamenial headaches in epilepsy, and that's mostly seen in female to male transitioning. So in these cases, male to female, they're going to be getting more estrogens and probably worsening some of these catamenial type pictures. But female to male, you get an improved picture because you're being exposed to more testosterones. And here's an area that really deserves to take a good look, because we do know that sex hormones clearly can contribute to MS. So when you look at the different transitionings here, a male to female, so more exposure to estrogens, they may have an increased prevalence of MS, earlier onset, increased relapse rate, and increased volume of inflammatory, so gadolinium enhancing lesions. But when you look at it the other way, female to male with increased exposure to testosterone, what we see is worse disease outcomes. So males tend to do worse in this disease as far as like the rapidness of the rate of progression that does not come back down to baseline. So, and increase in gray matter atrophy, so brain loss over time, and more cerebellar involvement. So you can see in this case, you can worsen the disease both ways, but in different aspects. So I think that this is kind of low-hanging fruit for people to start to look at how we do research. And fact is that there's a lack of research dedicated to answering these specific questions. But even worse is the fact that a lot of the ongoing current studies and past studies never even asked the right questions to identify the subjects. So what can we do? The social justice curriculums, in trainee education, and I mean all the way down high school level, we need to be very clear about what is necessary and putting on real blinders in medicine when it is important to do so. Understanding that social determinants of health are not, it shouldn't be that your zip code, or personal choices such as your gender and your sexual orientation, those things should not determine your survival, and they shouldn't determine when you're going to die. What they should determine, or what should determine those things are more biology. And since we know that that's not true in social determinants of health, we got to understand that what's wrong is probably policies and politics. And we can all try to say, we stay out of politics and I don't want to get involved in that. But it is absolutely our responsibility to help drive policy and be involved in the politics, because those are the things that allow for vulnerable groups to be excluded. So research development, making sure that it is equitable and that it applies to everyone. So we need to identify subjects clearly, being inclusive and asking, like I said, the right questions. We need to recognize the dangers of labels in medicine. So I did this little, quick survey of my 8-year-old. And so I have, 3 children. They're all 8.5 years apart. So I have a 25-year-old, 16-year-old, and I have this 8-year-old who was sent here to destroy me, but I won't let it happen. He actually sat down with me and I made up some of these labels. And I wanted to see how he, looked at those labels in general and how he responded. So I showed him this one and he right away, dominoes. He knew it. He saw this one and realized that his word was disabled. He saw this sign, Nike, right away. This sign, Apple, very excited to say that. He saw this sign and he said Visa. I thought close enough. It's MasterCard, but it's interesting. An 8-year-old would know that. I know maybe it's my fault. And here he said recycle. And so I moved away from some of the product labels, the things that are just kind of in between. And I showed him something that's a little more contemporary, but there's not a real label, for this. And the first thing out of his mouth was COVID. Then I showed him this, a little bit of propaganda, trying to show him sort of where he's things that he's probably seen. And even though I picked this off the internet and he had never seen this particular symbol before, he said, "Oh, this means get the vaccine and wear a mask." Then I showed him this and he was right on right away. He said, "The boy is blue and the girl is pink." Then I showed him this and I thought he would be stalled. He said right away, "That's either non-binary or transgender. It's one or the other." And the one on the left is transgender. And the one on the right, the pairs there would be lesbian, female, or gay males. And but it was interesting that he had seen or heard or understood enough to even say that. And it's interesting how we can put labels on things, and that's fine. These are Nike and Apple and Visa cards or MasterCards, and that is okay. But when you apply them to people, such as in the case of the last 4 images, and you then assign a belief system or opinions about our feelings, it becomes increasingly difficult to then remain objective. And so I think we need to be very careful about, signs, symbols, but we've been programmed. I mean, I will not look at the ground and push a door open and walk into a restroom. Few of us would, because you could be surprised, but more and more they're trying to get toward, oh, okay, these are just restrooms. They're open to anybody, but they still make an effort to put two shapes on there. Somebody wearing a dress, and it's a horrible looking dress, and somebody apparently just wearing a suit that sticks to them from head to toe, and that's supposed to be the male. But I think that it's really interesting how we get stuck on these labels and how we could cause trouble in our own careers. So how we promote health equity, we need to educate ourselves, and we need to be sure that we're working to drive these policies that protects equity. Educators need to promote inclusion and belongingness, and institutions have to develop social justice programs. We need to remove labels. Layleen Polanco, up here in the upper right of the screen, was a trans woman and sentenced to, oh, actually not sentenced for anything. She was in Rikers Island because of some minor offense. They slapped on her a $500 bond to get out. She could not make bail. She could not afford to pay the 500, and so she sat there. And as she sat there, they knew that, oh, this is a transgender person. So where do we put this person? They decided to just put her so it was a male prison, but they put her in a special isolation, not with the general population, a very isolated area, knowing her medical history of epilepsy, and but feeling that her situation wasn't urgent. And since she didn't have the 500 to make it out of there, she would not receive the proper health care. They witnessed her on camera have what looked to them like a seizure. Well, and she had a history of epilepsy. So, but she's in prison under stress, or, she's jailed under stress. Maybe she's faking it. So they watched her. And after she stopped moving, they watched for another 47 minutes before they went in and found her dead. I also just showed this picture of 3 just examples of youth that are going through transitions, and really the mental health, needs to be evaluated and never forgotten there. I should say Layleen Polanco's family did sue Rikers Island for $5.9 million and won. So just in summary, I'll wrap up these pearls here. So there's a paucity of medical evidence that supports our clinical judgment and developing guidelines in trans health, especially in neurology. Policy changes are needed to encourage inclusiveness in research and education to help with these inequities. Male to female transition versus female to male transitioning exposes people to different cross sex hormones, and they have a differential impact on neurologic disease and outcomes. And when you're treating a transgender patient, remember, it is not the responsibility of the patient to limit medical legal issues and limit liability. It's their job to be there seeking medical care, and it's our responsibility to understand what it is that needs to be done. If we find information that says, okay, exposure to this particular hormone may increase the risk for this disease or may increase the risk for this condition to get worse, the answer is not to recommend discontinuation of gender affirming treatments or the transitioning process. The answer is to inform the patient, allow the patient to make an informed decision. You know, we deal with these things all the time where we know that the patient has diabetes and eating extra, you know, cakes and drinking soda is going to hurt them, you know, and you can say as much as you want, but the patients have a particular commitment one way or another to something, and we have to be able to understand how do we best address the issues. It starts with information. I just wanted to highlight Holly Henson here and all the work that Holly and Emily Johnson have been doing at in the field of trans health and um, doing studies that are dedicated to understanding this. They both work in epilepsy, and I just find it, you know, just fascinating how well the epileptologists are doing in trying to understand this, especially since it affects not just the therapeutic effectiveness at times, but it also impacts the outcomes for the patients. So there's a list of references, and thank you guys very much.